Welcome to the Association of Black Cardiologists Workforce Pipeline Initiative. Uh, Today's webinar is entitled Towards Legitimacy and Results in Achieving Diversity, Inclusion, and Belonging, importantly, and belonging in cardiology training programs. Today we have a terrific group of program directors, as well as a keynote speaker and fellows who will join us for this ABC webinar. Without further ado, we want to get started since there is a lot to cover in today's program. Unfortunately, we begin on a sad note as we will dedicate this webinar to Dr. Eric Sean Williams, who was a cardiac electrophysiologist who passed and exited this world way too soon at age 44 years old. Eric was a consummate ABC member. He was co-chair of the ABC Electrophysiology and Interventional Committee along with Dr. Kevin Thomas, and he co-chaired the ABC Heart Rhythm Society or HRS Joint Symposia during HRS in 2017 and 2019. Eric was born in Brooklyn, New York. He was a percussionist. He completed his bachelor's degree in applied engineering and physics at Cornell University and received his medical degree with honors from Harvard Medical School. He then moved to San Francisco, where he did his internal medicine residency at UCSF, where he also served as chief resident at the VA Medical Center. Following his residency, he went to Duke University for general cardiology fellowship, and then thereafter trained in electrophysiology at the University of Washington in Seattle. The ABC will miss Eric's vigor, his excitement, and initiative related to mentorship in particular, research, policy, and patient care. Eric's passing leaves a tremendous void in the ABC family and in our field of cardiovascular medicine. His brilliance will forever continue to shine as a bright light among us. Our thoughts and prayers go out to his beloved family at this time. Really difficult time. Would like to now have a moment of silence for Dr. Eric Sean Williams, 1976 to 2020. So it is only fitting that we are doing a workforce program. Eric Sean Williams, as you heard, Dr. Eric Sean Williams, really had a distinguished training career and career in general at a very young age. So one of the things that I wanted to highlight in this program is that ABC for nearly 50 years has been working to create transparent and plausible paths to cardiology for those with aptitude and interest in becoming a physician, not just only a cardiovascular physician. And the slide you see here, feel free if you're on social media to take a snapshot of it or just take a snapshot and tweet it. These are selected ABC pipeline programs, as you see, that ranges from middle and high school students all the way to faculty. Today's program is going to be focused on cardiovascular medicine training and cardiovascular fellows. And I want the fellows out there to know that the ABC has multiple offerings beyond the symposia that we run. We're socially distanced now, but as many of you know, and those of you who don't know, we actually have several programs during the year that pull in fellows and other trainees for learning related to medicine, cardiovascular medicine in general. We sponsor general cardiology fellowships with collaborating partners, including Morehouse School of Medicine, ABC Meharry Vanderbilt, and The Ohio State University. We also have an annual cardiologist in training educational program We also have a Dr. J. Brown abstract competition for fellows. We provide travel grants to scientific conferences, and many of you have already met Narissa Hayes, who is our fellows representative to the board. For subspecialty training, we actually provide cardiac EP fellowships. We've trained 21 fellows that were supported so far by these fellowships, many of whom have trained at Duke University, where Dr. Sean Williams trained in general cardiology, and Dr. Julie Damp, who's the program director. We have also supported 25 fellows in interventional cardiology for their subspecialty training. So wanted to just highlight, since this is a pipeline activity today, the myriad of ways that ABC has been involved in pipeline efforts to date. So without further ado, for this program about legitimacy and results in DEI and belonging cardiovascular programs, I would like to introduce our keynote presentation, which will be delivered by the dynamic and very thoughtful mentor, long-term ABC member, and true soldier related to improving the pipeline for African American and other minorities in medicine, especially Black men in medicine. Dr. Quinn Capers IV is Vice Dean of Faculty at The Ohio State University College of Medicine, and he's also an interventional cardiologist. Take it away, Dr. Capers.
Thank you so much, Dr. Albert, and I really appreciate the opportunity to be here with you. Thank you for the invitation. Thank you to all of the wonderful people on the call with us, the panelists, people that I respect greatly, and thank you to all of you who are tuning in. These are difficult times that we're living in, difficult times because not only are we dealing with the novel coronavirus that is killing us, but we have been dealing with racism, the second pandemic, we like to call it, racism in America. And the last 5 to 6 months, it's been incredibly difficult as we watch coronavirus disproportionately impact communities of color and racism disproportionately impact people of color. As the entire world has been calling for an end to racism, it is gratifying to see that academic medical centers are making their own anti-racism statements. You have here a few of them that I'm showing you, but I'd like to say that the most powerful anti-racism statement that we can make in the medical profession is to diversify our profession. So the most powerful, the most durable anti-racism statement that we can make is to diversify our ranks. Each of these physicians, each of these minority physicians will practice medicine, we know, for 30, maybe 40 years. We know the role that physicians of color play in treating our nation's most disadvantaged patients. We know that a diverse training environment leads to everyone's cultural competency coming up. And we know that diverse research teams ask more innovative questions. So diversity truly enhances quality. And so if we're going to attack racism as a profession, the strongest and most durable way to do that is to enhance diversity. Next. So we're not there yet. And there are some barriers that have been there for a long time because we've been saying we need more diversity in medicine for years. The National Academy of Medicine, the AMA, the AAMC have been calling for diversity, but we're still not there. And there are some barriers. One is, believe it or not, doubt about the value of diversity or knowledge deficit about the value of diversity on what I like to call the in-game process, selection processes, medical school admissions, residency selection, fellowship selection. Our processes could maybe do better about being more mission-based and having evidence-based criteria that we're looking for in our trainees. There tends to be an indifference to an active, strategic, long-range plan of recruiting for excellence and recruiting diversity for excellence. And there's bias. There's bias in the system from the beginning to the end of the system. So let's dive into that just a little bit here. Next slide. I like to start with this question. Do you believe it? Do you believe that diversity enhances quality? I put that in as big as font that I could put it in and still fit that on the slide. And the reason I asked that, first of all, I realize if you have registered and logged on to this, then we're probably preaching to the choir. You believe, you're a believer. But you also know that not everybody believes that diversity enhances quality. It's so important because when you do believe it, then you have the energy to break out of the inertia and do things in a different way that will allow you to enhance diversity. If you don't believe it, or if you're lukewarm about it, then you continue to do things the same way you've always done them. Next. So I'm going to share with you some comments from a recent survey done by the Society of Thoracic Surgeons. And in this publication that came out in 2019, the Society of Thoracic Surgeons surveyed their membership about their attitudes for diversity. And they wanted to know a few things. What are some barriers to diversity? And if there's a barrier other than what they listed, then please give us more. And how can the Society of Thoracic Surgeons improve diversity and or inclusion in cardiothoracic surgery and or the society? So that was the purpose of the survey. They asked some closed-ended and open-ended questions. But let me just share with you some comments made anonymously. Next slide. So these are comments from the membership to the open-ended question. The first one says, white males are currently being discriminated against in admission to college, medical school, and residency programs. Cardiothoracic surgery should be a meritocracy. Someone else said, I do not believe barriers exist. This myth of the necessity of diversity and inclusiveness is political correctness on steroids. We need to worry about turning out well-trained residents. Someone said the STS doesn't need to address diversity, and this should not even be on the radar of things to be done. About 15% of respondents agreed with that comment. And finally, somebody said there are no barriers. What barriers? None of the above are important. Next slide. Well, those are cardiothoracic surgeons, and I'm an interventional cardiologist, and you know, we have a love-love relationship between interventional cardiologists and our cardiac surgeons. And so we poke fun at them, they poke fun at us, but we don't want to only poke fun at them. This is a paper recently published along with several of our co-panelists today, Dr. Julie Damp, Dr. Donna Polk. And in this study, Dr. Polk, Dr. Damp, and others, we decided to survey cardiology fellowship program directors to find out about their perceptions about diversity. 57% of cardiology fellowship programs in the nation were represented amongst the respondents. And you see there the breakdown between general and subspecialty cardiology programs. Next. This is one of the first questions we asked on that survey. We said diversity is a driver of excellence in healthcare delivery. In other words, the more diversity represented amongst your providers, the better the care delivered to patients. Do you believe this? Well, fortunately, almost 70% said yes. 5% said no, I don't believe that. And 25% said maybe. So 30%, 3 out of 10 of program directors who responded to the survey aren't sure if diversity enhances quality. Next slide. We also wanted to know a few other things. We wanted to know when we're making our rank list, kind of the final thing that happens. When we're making our rank list, what's on the mind of our cardiology fellowship program directors? So what we did is we gave 10 characteristics of applicants. And we said, please rank these according to which are in your top 3 considerations for when you're making your rank list. Next slide. And here you see the results. So the top vote getter was clinical skills. I don't have any problem with that, and I'm sure you don't either. Number 2, though, was ability to fit in. And I wonder if that means the same thing to you as it does to me. And you see the rest of them there: research productivity, strength of the residency program director's letter, on and on, go all the way down to the bottom. And all the way down at the bottom, you'll see diversity / ability to enhance the cultural competency of the program. So it is literally the last thing on the minds of cardiology fellowship program directors when they're making their rank list. Now, program directors are under a lot of stress. There are a lot of things to do for GME, and they have a lot of priorities. But this gave us a hint into what's going on when they're in that room making the rank list. Next. So do you believe it? Do you believe it? Are you like 70% that believe diversity enhances quality, or are you like the 30% you're not quite sure. So we're going to say that you believe it. And I like to think of a framework like this about what we have to do to enhance diversity in medicine. We've got the deep pipeline, and that's going way back to elementary school, because we have data that children between the 4th and 6th grade stop believing that being a doctor is a reasonable expectation. Minority children, something happens between grade 4 and grade 6. And then the short-term pipeline, those are the people that we can actually see when we look around the corner, pre-med students and medical students. And then finally, what I call the end-game selection processes, medical school admissions, residency and fellowship selections, and ranking. All of these are critically important, but it should be obvious that one is not more important than the others. I've spent my time as a former admissions dean and a former program director working on the in-game selection processes. But that in itself clearly is not enough, because if all we have is a trickle in the pipeline of minorities coming towards us for fellowship, then if we're tweaking the selection process as much as possible, then one year you will be successful at getting those 3 underrepresented minorities to go to your program. The next year, I might be more successful at convincing them to come to my program, but we all need to be working on the pipeline as well. On the other hand, if we're only working on the pipeline and the selection process is still biased, that's no good either. So we have to work on all of these together. So go ahead and hit the next slide there. So in the deep pipeline, we're talking about reaching back to our students, as you saw ABC has been doing, high school and elementary school. Next, on the short-term pipeline, these are our pre-med students. They need to see us. They need mentoring, advising, coaching, and they need for us to allow them to shadow so they can get really excited about our profession. And then finally, at the end game, we need to make sure our selection processes are free of bias and that we're using holistic review and mission-based processes. Next. So I'm going to show you some examples of what we could be doing here, and everybody can be involved in these. So this, I guarantee you, is the cutest slide you're going to see all day. These are kindergartners at their white coat ceremony. So the OSU Wexner Medical Center and Columbus City Schools have combined to create a K-12 Health Sciences Academy. These kindergartners are learning about circulation. They're learning about respiration, and they have the health sciences introduced in their curriculum from kindergarten through the 12th grade. Of course, our goal is to create more and more physicians. Deep pipeline. Next. And then I like to call this growing your own garden. Hit the slide. And if you look in this slide, our 4th grade program, where students come in to what we call our heart school and dissect hearts and learn a little bit about heart attack. If you look at the young man all the way to the left in the first picture with his arms folded, he's lost his certificate. He's in the 4th grade and he's trying to look cool. And, you know, when I think about it, when I think about being in the 4th grade, I can't imagine anything that was more important to me than looking cool in front of my friends. And so he's looking cool in front of his friends, which would make you think he's not interested, but that's not true. Hit the next one. This is him as a pre-med student at Northwestern University. Next. And then to the far right, this is him as a 2nd-year medical student at the Ohio State University College of Medicine. So that's from 4th grade to medical school. And I like to joke that I'm not sure how many 4th grade to medical school cycles I have left in me, but this is something that we can all be doing. When's the last time you sat down with a 3rd or 4th grader and said, I believe you can be a doctor? It does wonders for the soul. Next. Mentor relentlessly. Hit the slide. So we have put together a Black male roundtable at our medical school. We've been doing it for 6 years, where we get our attending physicians and our medical students together to keep these young men on track. In person, we meet quarterly for dinner, advising, socializing, etc. Hit the next slide. And of course, in the pandemic, we've now had to do that via Zoom. But take a look at this Zoom meeting, if you will. And imagine you're a 1st-year medical student. You might be the first in your family to go to college, certainly to go to medical school. The jitters that you have, the imposter syndrome that you might have. And imagine being on a call like this, where you've got the first chair of anything at Johns Hopkins University, Dr. Bob Higgins, a chair of surgery. You've got Dr. Andre Campbell, a trauma surgeon who is a celebrity surgeon. He's on MSNBC every other week. You've got the president of the National Medical Association, people who look like you telling you, you can do it. And yes, you do belong here. That is something that's very powerful. Next. Being visible on social media, hit the slide. Here is our Twitter campaign, hashtag Black Men in Medicine, where we want to flood social media with images of Black male physicians to encourage young people to speak out against injustice and to change the nation's unconscious bias about Black men. Next. Using social media. We have to use social media, and we still probably aren't tapping the potential to put out these images that show that diversity does enhance quality, and it makes us all better. Next. Recruit actively with long-range goals. Hit the slide. It was 2013, if you look at the graphs, when we realized at Ohio State that although we always had at least 50% of women in our applicant pool, that as of 2013, in 100 years, we had not fielded a single class of at least 50% women. We found that to be a problem. So we commissioned a task force to study the problem, give us recommendations, which we then put into action. And what we found when we put these new strategies in place, that now 7 years in a row, we've had slightly more women than men in our incoming classes. The picture is a special moment for me because these are 4 women that I admitted to medical school. And I'll tell you, Michelle, one of the real pleasures you're going to have as an admissions dean is being admissions dean long enough that you wind up working with physicians that you admitted to medical school. This is what it looks like when you are strategic about recruiting. Next slide. We call this the mentoring cascade. Go ahead and hit the next 3. The picture to the far left, you're looking at the first 2 Black cardiology fellows at The Ohio State University. The young man is named Sakima Smith. The picture in the middle is him teaching our students. He's now on the tenure track. We recruited him after the fellowship to stay on the faculty. And the picture to the far right is him standing in his NIH-funded basic science research lab. And so I mentored him. Now he will mentor others. Look at those young men. We're going to encourage them to go into academic medicine so that they can mentor others. And that's what we call the mentoring cascade. Next. Confronting bias. Hit it. So we wrote up this paper that showed when we actually tested our medical school admissions committee, we had them take the Black-White Implicit Association test. We found that a majority, more than 50%, have what we call implicit white race preference, which means when I see a white person's face, my automatic unconscious association is with positive things. And when I see a Black person's face, I automatically, unconsciously associate them with negative things. Next. Here's the raw data showing that 52% of the women and 64% of the men on our medical school admissions committee have this unconscious white race preference. That means when they see this, a Black person's face, the automatic association is with violence, pain, fear, misery, danger, etc. Next. So what we worry about is that this young man applying for medical school, he's done all the right things, right? New suit, handshake, smile, eye contact, all the things we tell our mentees to do. Hit the next slide. But if his interviewer looks at this young man and unconsciously associates him with a negative or violent image, then I wonder if he is grading his essay the same way. I wonder if he's grading his interview answers the same way. These are the kinds of things that keep admissions deans up at night. What we found, though, was that after unveiling those results and having our entire admissions committee participate in implicit bias mitigation workshop, the very next class we admitted was the most diverse class in the history of The Ohio State University College of Medicine. Next slide. So we've now operationalized implicit bias mitigation and made it a part of being on the admissions committee. We wrote this paper to show how to operationalize this in a stepwise manner. Next. And one of those steps you see here, we put together an implicit bias reduction cheat sheet, an actual sheet that has on it research proven strategies to reduce implicit bias in a one-on-one situation. So our interviewer has spread in front of him not only the credentials of the candidate he's about to interview, but also this implicit bias reduction cheat sheet so that they are fresh in his mind, these strategies, when he interviews. Next. In our latest paper, we actually are proposing a new teaching tool similar to morbidity and mortality conferences, where we actually are saying that you should get together quarterly with your patient care team to go over racist incidents on the wards that can put patients at risk. This is a way to confront not only implicit but explicit bias. In this paper, we list some case reports. In one of them, we were rounding. We went into the room of a patient with new onset congestive heart failure, a Black man. We talked to him, made a plan, came out, and when we came out of the room, the resident said, "Oh, I forgot to tell you, his drug test is negative." And the attending said, "Why do we do a drug screen?" And after some circular conversation, it was clear that there really was no reason to have done a drug screen. And the team was reminded that just 2 weeks ago, we had 2 white patients with new onset congestive heart failure, and nobody did drug screens on them. That's the kind of incident that we want to discuss in an educational forum so we can talk about what went wrong and how we can reduce these incidents in the future. Next. Engage the gatekeepers. Next. So we invited cardiology fellowship program directors for the first time to the Hart House in Washington, D.C. To have sessions about many things, amongst which were enhancing diversity. And we had a case-based implicit bias workshop, which we think all fellowship programs need to be doing. Next. And here's one of our latest papers where we are acknowledging that, as you know, the ACGME has now said that your program must show efforts to enhance diversity in your fellowship program. That might make some program directors nervous, but we say, don't be nervous. We'll show you how to do it. Just follow these steps. These are things that we can all be doing. Next. And what if we made diversity, or the ability to enhance cultural competency, what if we made that a top priority when we made our rank list? What would that look like? Next slide. Well, we have been doing just that in our interventional cardiology program for years. So here you're looking at the actual interview sheet that we use when we're interviewing our candidates, and we will rate you. If there's somebody out there planning to apply to interventional cardiology at Ohio State, know this, you will be rated on whether or not your letters of recommendation actually cite your cultural competence as a trait. You will be rated on whether or not you've participated in community outreach activities. You will be rated on whether or not you have been exposed to cultures other than your own. And you will be rated based on whether or not you have been exposed to underserved patients from vulnerable populations. There was some initial pushback when we went to this, with some saying, Quinn, you're choosing proceduralists who need to be good with their hands. What difference does it make if the person is going to be putting a wire down the LAD and out the diagonal in a STEMI patient has been exposed to different cultures? And our pushback to that pushback was, that's exactly who I want expanding balloon and blocked arteries, someone who has a respect for other cultures. So what would that look like if we made this a part of our selection process? Next slide. It would look like this. These are interventional cardiology fellows at The Ohio State University. We have 3 fellows in our program, and each year for the last 8 years, at least one of them has been an underrepresented minority. Starting top left, that's Moses. He's our fellow for 2020, but 2019, 2018, 2017, going all the way back to 2013. This is what it looks like when you truly believe that diversity enhances quality, because it's something to be sought. And you put together a pathway, a process to make sure that you are enhancing diversity in your program. Next slide. So from barriers to action items, doubt and the knowledge deficit about the value of diversity. Next, and you can just go ahead and click through all of these. We recommend journal clubs, online modules, get the data out there, because there's a plethora of data showing that diversity enhances quality. And so if people don't know it, let's get the information to them. Selection processes not being mission-based or evidence-based, we can retool our screening, interviewing, and ranking processes. Indifference to strategic long-range recruiting, let's hit the deep pipeline and the medium-term pipeline and recruit our fellows to be on the faculty. And bias, we can operationalize bias mitigation strategies. Final slide. I'd like to end with this, a very special piece of art. It's one reason it's so special is because my daughter is the artist. And what you're looking at is what it has been like to be a Black physician in the United States in the last 6 months. The doctor feels like walls are closing in on him. That's what you see in the picture. To his right, he sees a virus that is killing his community. To his left, he sees racism that is killing his community, while in the background, cities are burning. We don't have to be this way. The whole world is calling for an end to racism. Our part in the medical profession is to do the very best we can to enhance our diversity. Thank you very much.
Thank you very much, Quinn, for a data-driven presentation with positive solutions to help mitigate the challenges related to legitimacy and results in achieving D&I, as well as belonging in cardiovascular training programs. So now we're at the point where I want to introduce our panelists. We have a distinguished group of panelists. We have 8 program directors from some of our top training programs across the United States. So we have geographic spread, as well as we have 3 surprise trainees who will also be part of this. So without further ado, I just want to quickly refer you to the flyers that you received to get a deeper dive into the program directors, but I will introduce everyone right now. And then we'll open up, I'll open up with the first question. So our first panelist is Dr. Donna Polk, who's an associate professor of medicine and the Cardiovascular Medicine Fellowship Director at Brigham and Women's Hospital at Harvard Medical School. Then we have Dr. Frank Silvestri, who's an associate professor of medicine, an associate chief of education and director of the Cardiology Fellowship Program at the University of Pennsylvania School of Medicine. We have Dr. Venu Menon, who is the endowed chair and professor of medicine, the Mehdi Razavi endowed chair and professor of medicine and section head of clinical cardiology and director of the cardiac ICU and director of the cardiology fellowship program at the Cleveland Clinic Lerner College of Medicine. We have Dr. Melvin Eccles, who's an assistant professor of medicine and director of the cardiology fellowship at Morehouse School of Medicine. We have Dr. Julie Damp, who's an associate professor of medicine, director of the Cardiology Fellowship Program, assistant director of education development program at Vanderbilt University School of Medicine. We have Dr. Carol Watson, one of our own ABC members as well, who's professor of medicine. She's a population scientist. She's co-director of the UCLA Program in Preventive Cardiology. She's director of the UCLA Barbara Streisand Women's Heart Health Program and director of the Cardiology Fellowship Program at the UCLA David Geffen School of Medicine. We have Dr. Stephen Marks, who's the Herbert and Florence Irving Professor of Cardiology and Director of the Cardiovascular Medicine Fellowship at Columbia University, New York Presbyterian Hospital. And Dr. Donald Clark, or Trey, who's the Assistant Professor of Medicine and Director of the Cardiology Fellowship Program at the University of Mississippi Medical Center. So I want to thank you very much for joining us as panelists. So I'm gonna start with the first question. And listen to your answers, then I will introduce our 3 trainees. So the first question, which is a question for the entire group, is what are challenges or barriers, whether at the societal level, and you heard Quinn outline the pipeline challenges to recruiting underrepresented in medicine residents to cardiovascular medicine fellowship and increasing diversity within your program. So why don't we go across the screen and start with Dr. Menon and then and move in a clockwise and counterclockwise direction with the squares.
I think it's, thanks Michelle for having us participate in this. It's difficult to beat Dr. Capers after he defined what the real issues are, but let me put my perspective as a humble person at the other end of the spectrum. You're faced with a match list and a group of folks who you're considering for an interview. And I think the challenges that come up there are a couple. One is exactly what Dr. Capers said. The current situation puts me in a situation where, despite my best intent, some years I win and some years I don't. And that's because I go ahead with best intent, put the people I have in a rank list, and the rank list is the match is the best thing for this, because you want people to choose where they want to go and what they do. And sometimes I lose to Julie, and Julie recruits someone I really want, and it's on her list, and sometimes I don't. I think that is, it is, while it's not a challenge, we really need the match. I think the key here is I need to have 5 people in my match, so if I miss on one, I get 4 others. And so I really think that our focus really should be in getting as many folks in internal medicine, which is the closest proximity to a program director, both at our institution and around the country, to be applying for cardiology. Because when you take a look at the number of positions, there are plenty of cardiology positions. It's 900 positions, it's about 600 American graduates. But we really need to make that connection and get more people interested in cardiology. And I think Dr. Capers outlined many of the fantastic ways he's been doing that, but that can't be something that's restricted to Columbus, Ohio. That needs to be in every city around the country.
Thank you, Dr. Menon. And what we'll do is we'll go around and have everyone give their input to the question. And we'll also ask that if we can try to keep our comments to about 1.5 minutes to 2 minutes, just so that we can come back with follow-up questions. Dr. Dam.
Thank you. I echo everything that Venu said, and I think Quinn did a great job of outlining some of those pipeline issues that I think we all as program directors face. A couple of the other things that I would mention is diversity of faculty and diversity of your institution can also be an important piece from a barrier standpoint, and geographic location and can be an important piece as well. Sometimes if you can highlight geographic diversity in your community or diversity in your community geographically, that can be an important piece to applicants who may not know much about your city or the area in which you live.
Thanks, Dr. Dam. Dr. Polk?
I would echo exactly what Julie had said. I think it's about diversity of faculty, people looking for potential mentorship, even if it's not what they want to do for their research, but having that panel of mentors that you gather as you go through your academic career. I think without somebody on the faculty that you can see as that potential mentor, I think that's a big challenge and a big barrier for recruitment.
Thanks, Dr. Polk. Dr. Lynch? Dr. Clark, sorry.
Hey, thanks. Yeah, so I also want to thank you for the opportunity to be here and participate and discuss this very important issue. I suppose our program at University of Mississippi Medical Center may be somewhat different compared to the other programs here in that we are a public state institution, and we're the only academic medical center in Mississippi. And as many of you probably know, Mississippi has significant challenges in terms of shortages in the physician workforce and access to care for underserved patient populations. And so it's very much a part of our program to recruit and retain cardiologists to work in Mississippi and take care of our citizens here. And so broadening our pool of applicants to include a more diverse pool of applicants is extremely important to us. And so how we deal with that, I think Dr. Capers, who's written on this and just spoke about it, with the short-term and deep pipelines that I think are uniquely relevant to programs like ours, where we really need to develop these pipelines in our communities and our state, in addition to working on the selection process. So that's a peek into our program, and look forward to further discussion.
Thank you, Trey. Thank you, Dr. Clark. Dr. Marks?
Sorry, thanks also for the opportunity to talk today amongst this distinguished panel. I agree with everything that was said. There's issues about pipelines and faculty. Having examples of faculty members who've been successful in the program is so important for our successful recruitment efforts. Otherwise, we have some years we're extraordinarily successful and some years we're just not as extraordinarily successful. And so developing a faculty base is so important. other issues that I see as a problem is that, you know, when we're flooded with applications, as everyone else is, especially this year, it's seemingly that there's more applications than ever before. Many of these applicants are extraordinarily polished. They have incredible CVs, incredible letters of recommendations, and it's hard to ignore that many extraordinarily polished, high, you know, impact papers, great letters of recommendations are influencing decisions by the selection committee more than other things might be factored into these decisions.
Thanks, Dr. Marks. Dr. Watson.
Thank you again for this amazing panel. And I really can't tell you how much the ABC has meant to me and so many like me in paving us to our careers in cardiology. So I agree with what everyone has been saying about the pipeline issues. And I love Dr. Caper's program. If we could take his microcosm and expand it to the world, we'd be such a better place. And I'm grateful for him. But we can't. And unfortunately, the systemic issues remain. And you have to get buy-in from everyone to believe exactly as Dr. Caper said, that diversity matters. And we are so much better with the diversity of thought, opinion, race, religion, you know, sexual, everything. So we have to get buy-in that diversity matters. And I have to tell you, you know, see, you can't be what you can't see. And I have to tell you my story. When I was a medical student and had a different career path envisioned, and someone dragged me to the Association of Black Cardiology meeting, and that changed my life. And I will never be able to give enough gratitude for that, because I never would have believed I could do it if I didn't see it. And the number of mentors that I made along the way who have continued to mentor me and write my letters for advancement, etc., is just you know, beyond, I can't even begin to give enough thanks. So I think we have to get the buy-in from the larger community, including not just African Americans. It has to be everyone's responsibility to bring all of us along.
Thank you, Dr. Watson. Dr. Eccles.
Oh, thank you, Dr. Albert, for inviting me to this amazing panel. First and foremost, I want to say my heart and condolences go out to Eric Williams' family. As a former Duke trainee, I'm really saddened to have lost such an excellent guy. I want to say, in terms of program-specific challenges, just a little bit about our program. Our program is probably the youngest cardiovascular fellowship program on this panel, which not a bad thing. We are part of Morehouse School of Medicine, who has had a mission from day one to increase the diversity of the workforce and the scientific workforce. So I think we are definitely in line with that mission. Our program was initiated because of that. We have people such as Dr. Elizabeth O'Philly, who has worked with Morehouse for 20 years in the making of this program, who was actually one of my mentors when I was a medical student at Morehouse. And so it's exciting to be back to work with her and continue to fulfill the mission that she set out to pursue. I think in terms of challenges for our program right now, we're young and we're small. You know, the only challenge I feel that I have right now is I can't accept or take as many applicants as I want, where I'm sure many programs feel the same way. But on a societal level, I think that we should understand sort of the definition of an underrepresented minority is not always a one-size-fits-all definition, meaning that I feel that there aren't enough targeted grassroots programs, for instance, to actually help with improving underrepresented minorities overall. For instance, I applaud Dr. Caper's work, and his career is phenomenal to me. They've actually accepted one of our fellows for interventional cardiology, which I'm extremely excited about. But I think that there are too many, like Dr. Watson said, I think there are too many in silo efforts that would be wonderful if we could actually branch out. Personally, As an African-American male, I'm sensitive to this topic, as African-American men in cardiology and medicine overall have continued to decline over the years. And so it is our mission to make sure that we support advancement equity of all underrepresented minorities.
Thank you, Dr. Echols and Dr. Silvestri.
There we go. Can you hear me? So great, thank you. It's such an honor to be a part of this conversation and learn from everybody here. I guess I'm going last, so which means most of the things and most of the challenges people have already mentioned, and I agree with all of them. I want to throw out one more, which is thinking about the culture and the climate of the programs that we exist in, and the program director as having a power, but not all of the power to change the climate and the culture. And I think Dr. Watson alluded to this as well. So I think that we need to hold ourselves accountable in terms of representation, but then we also need to create an environment where people are absolutely comfortable, absolutely cared for, and are empowered to succeed. And I think that that's an enormous job. I have 153 faculty in our programs, and we need more Quinn Capers, and we need more people like everyone on the panel. And that's a lot of hard work to do that we all have to do in the trenches.
Thank you, Dr. Silvestri. So listening to your comments, there are certain themes that just came out. One has to do with further along in the pipeline, which relate to faculty and mentors. And, to paraphrase Carol, can't be what you can't see. So that's part of it. On the very beginning end, but also while you're in a program or a residency program, or even in or medical school, not seeing the faculty who would be there to mentor you. One of the things, though, that I have to give pushback on is, I have the opportunity to talk to a lot of Black and Hispanic and other underrepresented minorities in medicine, who are attempting to, sort of get out of their residency programs and apply to cardiology. And despite there being, I heard 900 spots across the country, they describe really significant challenges in even getting interviews at the cardiovascular medicine programs. And then once they get the interviews, the welcome, and Dr. Silvestri, you talked about culture and climate. They go to their interview day and they feel that nothing was done in the program to actually show them that they could be a part of the institution that they're visiting. So I want you to, sort of comment more about two things. And not everyone has to answer, just a few people can answer this, is why is it then that coming to the ABC, there are so many trainees who come to us saying, we can't get into a cardiology program, or we can't, get an interview. Could you enlighten the audience about that?
I don't know how enlightening I can be about that topic, but I definitely, acknowledge, and I think everybody on the panel probably does as well. One of the things that I think is so problematic about our system currently is our screening process. So this is my first year. So I have previously been associate program director. This is my first year as program director of our program, and we got 860 applications this year. And so how, the methods that we use to go through and filter those applications are not evidence-based. They're not great, and they feel really uncomfortable as you're doing them. And so I think that, we need to, as a community, I myself need to, and, us as a program director community, think about how we are screening and assessing applicants.
So Dr. Capers, you mentioned evidence-based, and you just put your hand up. I was going to pivot to you to ride on that wave.
Sure. Thank you. So I think I have a couple of things I'd like to say here. First of all, when I became the Dean of Admissions at Ohio State in 2009, I was shocked when I walked in and found out that 5,000 applications were being screened by 2 people. And so you can imagine how holistic you can be with that kind of ratio. And I thought, why is nobody helping with this? And again, it was the inertia, Bill, because this is the way we've always done it. When we sent out a letter to the faculty at large asking who would like to help us review applications, we'll teach you, we'll show you what we're looking for, we'll show you the mission, we'll show you how to do it. But who would like to volunteer some time to do that? We had to turn people away. We cut it off at 90. So we went from 2 people screening applications to 90 people screening applications. And that was really very important, because now that allows you to really do that deep dive. The other thing that I think is so important is having an actual stated mission. And I don't mean the mission of a medical school or an academic medical center, because as we all know, those tend to be kind of multi-stanza, multi-paragraph, multi-page mission, vision, values kinds of things. But what is the mission of your fellowship program? If the mission, for instance, is to produce academic cardiologists, then you probably have some system where you would give the nod to somebody who's published 3 papers as opposed to 1, because that's your mission. And that is predicting that somebody might be more successful long-term. If your mission includes diversity, producing cardiologists to care for a diverse America, then that should lead, there should be a straight line drawn from that right to your interview questions, like on that sheet that I showed as an example. So those are some things that we can do to expand the number of screeners. And I think to really be mission-based. And when I say mission, not just the traditional, like most people would say, well, our mission is to create the best. Well, no, I mean, what is the actual mission of your program? And that could be a worthwhile exercise for you and your stakeholders to come up with a mission for the fellowship program. And then finally, regarding an evidence base, this is a medical school story, but it works very well with GME as well. In the previous iteration of the MCAT, as many of you might know, the scores were from 0 to 45. 45 was if you got every single question right on the MCAT, you would get a 45. So we didn't see that very much. Our average at Ohio State was 34 for the incoming class, which is very good. That was 94th percentile. And I got tired of hearing in our discussions every time something like this. Boy, this young lady has everything we want, but boy, oh boy, am I worried about that MCAT of 26, because our average is 34. And I don't know, I think she might not be able to get the work done. And then we haven't done her a service. So we got together with our statisticians and looked at 10 years worth of data of entering MCAT scores versus graduating on time and versus passing USMLE Step 1 on time. And what we found out is that there was no difference between 34 and 45, and very little difference all the way down to 25. So that allowed us to make our cutoff 25. That was an evidence-based cutoff. Often, and I'll bet you, Michelle, that these students that you're seeing or residents at the ABC who are saying, I can't get an interview. I'll bet you that some of it has to do with Step 1, and that our programs, in an attempt to get it from a large number down to a small number, have some Step 1 cutoff that actually is an anti-diversity strategy. You should have some evidence base for your cutoff. Is your cutoff 240? Is that because 235 doesn't do well in your program? Or did somebody pick 240 because that helps to get the number of applicants down?
So Dr. Capers, I'll pop in here. You have touched a nerve that I think is something that ripples through the entire community of UIM trainees, which is the use of standardized testing across the board, whether it is from going into college, all the way to board certification, that actually keeps UIM out of positions taking care of their community, being in positions of power throughout the pipeline. So this is, an important, topic, important issue that we need to grapple with. And you're right, there's the MCAT validity study that is showing that there's a wide range with the new MCAT, 502 to 528, that represents a group of folks who will, 96% of them will go on to graduate medical school. My other comment before I go to Carol is that, if you use a quote unquote cognitive measure to correlate with another cognitive measure that's close proximity to the entrance into a program. So if you use an MCAT score or a USMLE score, it will correlate well with another measure that has structural problems and structural, actually, I dare say, structural racism related problems, because all of it is tied into the availability to have appropriate, training, test taking ability over time. So we're using, I believe, the wrong correlates. Dr.
Yeah,
Watson.
thank you guys. Again, a really big problem. And we forget the best predictors of scores on all of these tests are your parents' income and education and your educational opportunities. So what we are doing is institutionalizing racism, because the people who don't have those opportunities don't have the same scores, and they end up being filtered out. It's kind of insane and circular when you think about it.
So Michelle, this is Venu. So I've taken a different track over the years. I now start by reading the personal statement first. That's the first thing I read in an application before I go on to where did they train and what did they do. That gives me, hopefully, it's eliminating some bias and giving me some context into who this person is. I can't measure it, but I think that's made me a little better in terms of me not being a prisoner to a number and seeing those kinds of challenges. And I think for the young students and applicants in the room, I think one thing as a program director I would say is don't underestimate that personal statement and your ability to state your story and your path and your goal. I think as program directors, we find that very inspiring, and that by itself may be the only thing you need to get a great interview. And I think people underestimate the amount of work they put in that statement, because there are great stories to tell.
Right. I think another issue that often comes up with applications, whether it's residency applications or fellowship applications, is that, there are letters of recommendation. And oftentimes, a letter of recommendation may say, this person is very good or excellent or outstanding or exceptional. Typically, there are also behind the scenes conversations that oftentimes will occur between program directors and residency programs, and the trainees are often left out of this and not privy to it and wonder. So there's this also cloak of secrecy that also exists that is also structural, especially if you are from a socioeconomically disadvantaged background, wherein you have not had certain types of exposures. So I think, transparency in the processes is probably another part of this equation. What I want to do, paying attention to the time here, and I do want to get everyone to make comments, but I'm going to ask our three trainees to introduce themselves. I'm going to have them introduce themselves at this point, and then ask their questions. And again, I'll encourage those of you who haven't spoken so far to take on any one of their questions. So we'll start with Dr. Rimsey Dennis, who's a cardiovascular medicine fellow, fourth-year fellow at Johns Hopkins University.
Hello, good afternoon. It's a pleasure and honor to be amongst this group this afternoon. Thank you again for this opportunity. My name is Rimsky Dennis. I'm a fourth-year research and clinical fellow at Johns Hopkins Hospital with future plans of completing interventional and structural cardiology here at Johns Hopkins.
And Dr. Dennis, do you want to ask your question?
Sounds great. Well, over the past hour or so, I've been amazed at this great discussion that you all have had. And again, I'm excited, as a fellow who recently went through the process of matriculating into a fellowship program. My question to each of the program directors pertains to what efforts, if any, are you all doing to obtain individuals from underrepresented minority groups? And how are you going about to identify individuals who are a true good fit for your program?
So maybe I'll pivot that question to Dr. Silvestri.
Sure, happy to take it, and I'm sure the other panelists will chime in as well. I think every step of the way, what we need to do is we need to enrich the population of people that we're getting to meet and interview, the population of people that we're recruiting into our program, and as I mentioned, then being able to give them the tools that they need to be successful and to feel like they're in a community. So it starts with the interview screening process. As you already heard, that there's a tremendous number of interviews, applications that everybody's getting. And what we've done is we've looked at everyone who is self-identified as underrepresented minority and everyone who's self-identified as female as well. And we screen them in a completely separate process. And the goal there is to take out a lot of the components that that would be, structurally racist or structurally biased in some way, and to really look at that cohort as a group of people that we want to be enriching our interviews with. And so we're already starting with an assumption that if we get to meet and talk with people, then we'll really get to know them and assess, how well we'll be able to help them meet their goals and how happy they'll be in our program.
Thanks, Dr. Silvestri. How might you respond to those on the other side of the aisle that say, are you giving preferential treatment? Are you disadvantaging those who are not being treated that way? What might your answer be, or what might the answer of any of our other panelists be to that question?
Well, my answer would be no, and obviously, I want to say out loud that our mission is to diversity, and our mission is that our clinical work, our teaching, and our research is better when we are diverse, and when we are representative, we are fulfilling that mission. And so I don't think that anybody is being disadvantaged or advantages. I think what we need to be doing is enriching the people that we're talking to, and we need to be enriching, the interview process as the first step in the place where I, as a program director, can get involved. But I would love to hear what other people have to say about that as well.
I would say from our program, we've embraced the virtual. This is a great year to be able to reach out. We've had open houses, Zoom open houses for all the different subspecialty areas within cardiology, had a diverse group of faculty. And that's led applicants to reach out to these diverse faculty members and ask for advice, pre-interview, post-interview, during interviews. And I think it's been a great success. We've also enlarged the number of interviews dramatically, given the fact that people don't have to travel. There's no barriers for us increasing the number of interviews, and we've markedly enhanced the number of interviews we've given out this year so we can meet more people. And I think the toughest problem, as for your question, is why people don't get interviews. We have 16 internal applicants this year. If we're going to only interview 50 or 60 people generally, that means we can only give out 30 or 40 interviews to the external group of people. But for this year, I can give out 90 or 100 interviews this year, so we can meet more people, and we can have a better pool of applicants for us to choose ultimately when we do get into that smoke-filled rank meeting room and figure out who we should rank.
Thank you. To keep the program going, I want to introduce our next, not trainee, but person interested in going into cardiology, Francisco Corrado Medrano from Zuckerberg San Francisco General Hospital, who is applying into cardiology. Francisco.
Thank you so much, everyone, for having the opportunity to be here and tell my story. This is the right place to be. And I'm from Guatemala. I'm Hispanic, and I'm hoping to apply next year in 2021. And while I'm preparing for this application process, I have learned that only 3% of cardiologists are Hispanic. And you compare that number with the Hispanic population in the US, which is 57 million, and being cardiovascular disease, one of the major causes of death among Hispanics. I feel very encouraged and motivated to be part of that group of physicians who are trying to help our communities. And as Dr. Capers mentioned, the literature has shown that language concordance care, cultural competency can improve, patient outcomes. During my residency training at Albert Einstein in New York, I felt very challenged when I was caring for patients who were older and had cardiovascular disease. Despite being in a very busy clinical training program, I realized that my exposure to geriatrics was very minimal. And that's the reason why I completed a geriatrics fellowship at the University of Pennsylvania. At that point in time, I wanted to combine my training in geriatrics and pursue cardiology fellowship, but unfortunately, I was training on their H-1B working visa, which was going to expire pretty soon. And I found myself in a situation that I needed to have a plan B, secure a job position, secure a permanent residency. And that's how I ended up at UCSF. Being a faculty, I've been devoting my time to clinical work, and I've been continuing my passion for geriatric cardiology by teaching medical students, residents, on how they can incorporate these principles into the care of their patients. And I also devote a significant amount of my time to develop quality improvement work, identify disparities among patients with language barriers, and improve the quality of care of this population. And these experiences have helped me to be more prepared to adapt quickly to the needs of our patients who have been affected with COVID-19. The majority of our patients have been Spanish speaking, and we have been able to deliver effective tools to communicate, highly complex medical information with patients who face, who English is not the first language and also face low health literacy. At the same time, I have witnessed how language concordance care can have a significant impact in patient care experience and the patient's medical understanding of their condition and adherence to treatment. And lastly, I would like to say that my goal is to fuse my passion in cardiology, language access, and geriatrics. And my question for you is, an applicant like me, as being member of this large pool of applicants who may be at disadvantage because we may have a gap in training for various reasons, or because we are foreign graduates, how can we improve ourselves and put us in a position like we can be more competitive to be able to match in one-year programs? Thank you.
Dr. Paul,
I start. Francisco, I sent you a private message. Call me. Someone like you would be very, very attractive because, again, we understand that diversity in all of its aspects makes us stronger. And I've always said to all of my trainees, your road doesn't have to be straight. It has to be steady. And you've shown steady progress in a number of ways with some really interesting background that make me say, call me.
Thank you so much, Dr.
Polk.
I would agree. I think that, I think we understand the issues with visas and things like that. So when we're screening things, I think we get that. And I think Carol is exactly right. If it makes sense what you're doing and that you're adding to your experience and your skill set, then I think that's what we look for. And I would just comment that I think that a lot of what we've talked about, I think the word that sort of resonates is deliberate, and being deliberate in how we screen, how we recruit. When we sit in the back room, that we're deliberate about what our rank list looks like. There could be a rank list that's there and it's like, there aren't enough women there. There are not enough URMs there. We need to think holistically about that. And it's just about being deliberate. And I think that that's how, we look at things. And I think that's the only way that we can be successful.
Thank you, Dr. Polk. Dr. Narissa Hayes is a fellow representative to the board of directors for the Association of Black Cardiologists, and she's a third-year cardiology fellow at UPenn, and she has a question too.
Yes, I do. Thank you, Dr. Albert, and thank you to all of the panelists thus far. So my question is, what steps have you and your respective divisions taken to create an inclusive, supportive, and welcoming environment for URMs, both for trainees and early career cardiologists, since we know that representation is very important and that cannot be overstated?
I think I can take part of this one. So I think really mentorship is key. As I said, I had some wonderful mentors all the way from med school on up. And so we have really tried to focus a lot of time in mentoring our fellows once they get here. I've even continued to mentor some after they leave, as well as mentorship of people who did not match in your program. Sometimes I've gotten emails from people that want to collaborate and want to work, and I'm all too happy to continue that relationship, because you never know when that person will come back as a faculty member or someone that is really passionate about your mission. So I think mentorship is just absolutely key at all steps.
I totally agree with Dr. Eccles about that. And I think that that's something that can be done also in a very deliberate and intentional way within a program, rather than just relying on fellows to find those people. Try to help make sure you're facilitating those connections. A couple of the other specific things that we, are working on in our program are trying to make sure that these conversations are happening in a very sort of open forum and public forum within the division. So having implicit bias based grand rounds, having diversity journal clubs. It made me so happy when Dr. Capers showed that implicit bias cheat sheet. We used that this year, and if he endorsed it, then that made me felt like I might be doing something right. So sort of doing some of those, things to open up the discussion and make sure that it's not a discussion that just a really small portion of the division is having. And then, one of the other things that I think is really important, and it's been touched on a couple of times in this discussion, and we, touched on a little bit in that paper from the program, and one of the papers from the program director survey, but this idea of how someone fits, I think has the potential. I think we all mean positive things when we say it and think it, but it has the potential to really perpetuate a lot of different biases that may be institutional, maybe cultural, maybe geographical. I mean, it has a lot of potential to go in a way that I don't think most of it mean it to go. And so trying to think about, for each trainee that comes in, how are they going to make our family here in our division better so they fit, but it's because they're adding in and having that mindset, as opposed to saying they need to be just like everyone else and that's how they fit.
I completely agree with what Julie said. One of the biggest barriers we have had is getting our 250 faculty members to buy in. And so we've done a lot of things like we've had Clyde Yancey come and talk to our entire division about why this matters. And I've just got a firm commitment from Dr. Capers to come give a grand round at UCLA as well, because everyone needs to hear exactly what you just said. The problem with academic medicine in many ways is, if I time traveled back 100 years, it looked pretty much like it looks now. The same metrics, the same people, the same older white men. And I think we need to get people tend to hire themselves over and over. So we need to get people to understand how important diversity is. And thank you, Dr. Capers.
Thank you so much for this really robust discussion. I'm paying attention to the time, and we have about 15 minutes left in our program. So what I want to do is I want to begin to move things forward. We do have some comments in the chat. One of the comments, so for those of you listening, will not directly be covered in my closing comments, but indirectly. So I won't pose that question to the group. One anonymous attendee states, at the time of application for fellowships, for some URM candidates, it's already too late to be competitive. Limited research opportunities and other antagonizing factors from other structural issues. How can we encourage URNs to earn their place in the programs as opposed to this notion that they are being treated specially because they would not otherwise have earned these positions?
I think I'll take that. I think that almost everyone who's applying for cardiology is extraordinarily qualified for the position and would do extremely well here or at any of the other programs that we're talking about. I do think to some extent, yeah, it is a race to have the best CV, but I don't think that we're giving anyone a break here. I think that everyone is extraordinarily qualified and can do the job. As a research fellow or a clinical fellow or both. And my feeling is anyone who matches here or anyone who we interview would do extremely well in this program. I don't think I'm giving anyone a break. I think that they earned it.
I would agree. And I think that I think that when we look at places, it's like, what are the opportunities? What did you make of whatever opportunities you had, whatever they are? And if you made the most of your opportunities, fantastic. That shows the trajectory you're on, and that's really all we care about.
Thank you. So thanks, Dr. Paul. So we're going to move to try to close. So I want to thank the panel for your robust conversation and frank conversation related to this topic. So I want to close out this webinar with a few slides. So one of the issues that was raised by all the panelists, but specifically by Drs. Damp, Dr. Polk, Dr. Marks, and Dr. Watson, relates to having a climate and faculty in place, particularly in leadership spots, to encourage the underrepresented minorities to actually come to programs, and also to create a climate among faculty that is one that's welcoming and that supports diversity, inclusion, and belonging. Dr. Capers discussed the pipeline as it relates to starting from kindergarten to cardiology fellowship. But a large part of the issue also relates to who gets the leadership spots in medicine. Who gets the leadership spots in medicine? Typically men, mostly white men. As you see on the slide, cardiology chiefs are largely in the top 40 programs, 24 are white men, 10 Asian men, 3 Black men, 1 Hispanic man. If you look at race ethnicity by professors, you'll see compared to whites and Asians, Blacks and Hispanics represent a lower proportion of full professors. And so that this pipeline narrows. So in all our circumstances, in all our schools, we cannot actually solve the pipeline problem without also paying attention to leadership. So in this paper that I had written as a perspective, #MeWho, flipping the script from zeal to inclusion and professional success in medicine, there were 4 categories, next slide, that were outlined with potential solutions. Pipeline barriers outlined, recruitment, retention, as well as senior leadership. Given the topic at hand here, one big issue is recruitment. Dr. Capers already talked about engaging middle and high school students. We talked about some structural factors. We brought out the issue of structural racism, structural discrimination, which can be embedded in success indices in schools. These include AOA nomination, rotation evaluation disparities that embed racism into our structures. The need to focus on national and institutional pipeline goals. So we all represent different institutions. However, as it relates to UIM in particular, I think that the institutions need to get together to help solve this problem. So it's not just a let's say, a Ohio State or a UCSF initiative. It has to be institutions connecting with each other. We have to also, to keep people there and retain and recruit, we have to understand and address barriers of social isolation beyond critical mass. So we're talking here about, sort of getting people in the door, but how do we keep people in the door? We have to address that as well. We may need to embed financial incentives to encourage faculty to be involved in these processes, as well as to support students and trainees as they come through. You've already heard about mentorship and sponsorship. We also need to develop early and life course academic mentored programs that equitably prioritizes all medical research and education disciplines. I can't say this enough. Many UIM are interested in going back to work with their communities or do research that is related to health equity. And traditionally, basic science disciplines and other such disciplines gain the recognition and promotion advancement that then leaves everybody else out. So this has to be a completely inclusive process. And as we talk about senior leadership, we know that leaders set the tone for what happens in our profession. We need transformational leaders judged on mentorship and sponsorship success. So you heard Dr. Capers talk about his activities in deeply, not just being a gatekeeper through the admissions process, but actually becoming involved with the communities that he's trying to recruit. You heard Dr. Clark say in Mississippi that attention is being paid to, or beginning to being paid to, what's happening outside of the institution in order to, sort of bring people in. So our leaders need to be judged on their mentorship and sponsorship success. We already talked about mentorship and sponsorship. Targeted leadership internships. Many UIM don't have the opportunity to be mentored by senior leaders, don't have parents who are physicians who can, sort of give them an inside scoop about what goes on. So UIM need to be tied into mentors and internships within institutions that will lead to advancement. Strategic assessment of pipeline promotion drivers is another thing. Cross-disciplinary and institutional leadership retreats. Regional and national networks promoting professional and social success. One of the things about the ABC is that you heard Dr. Watson mention this. Dr. Quinn Capers has also benefited from this. We've heard Dr. Clyde Yancey's name being mentioned. Myself, one of the reasons that we have been able to thrive in medicine, and there are many community doctors who are cardiologists as well, who are part of the ABC. The reason that we've been able to thrive, a core reason, is actually being able to interact with each other, being able to see that there are others that look like us in this process, and that there are others who have our best interests at heart. Sponsorship for nonprofit and corporate board participation. I think this is another water's edge for senior leadership. Next slide. So today, as we close out this webinar, I wanted to announce that the ABC will learn from its lessons in the past. And I think Dr. Capers can remember some of this as it relates to Ohio State University. Many years ago, Dr. Wayne Kong, when he was CEO of this organization, as well as others, Dr. Madhu and others, actually started an initiative where they kept tabs on cardiology programs who had never trained a Black cardiologist ever. And at the time, Ohio State was one of those places. And you've seen what's happened since then. So the Association of Black Cardiologists is launching a cardiology training scorecard. It's going to be called ABC DIBS, ABC Diversity, Inclusion, and Belonging Scorecard. You can think of it as a traffic light, where poor means that your program is not doing well on the metrics, diversity program characteristics. There are going to be 4 major characteristics, looking at UIM and general cardiology fellowships, looking at the change in the number of fellows over a defined period of time, usually a 4 to 5 year time, in your program, which is generally the life cycle of the training program, assessing program trainees' sense of belongingness, how welcome they feel in the program, and also looking at UIM faculty measures. What is meant here is how many UIM faculty do you have? How many UIM faculty are in leadership spots in cardiology in your training program? And so programs will be ranked as poor, at risk, or excellent based on these characteristics. These are things the organization will publish on a yearly basis. So thank you for joining our program today towards legitimacy and results in achieving diversity, inclusion, and belonging in cardiology training programs. Please, ABC is open always to new members. You don't have to be African American to be a member of the ABC. ABC is focused on saving the hearts and minds of a diverse, and I repeat, diverse, D-I-V-E-R-S-E. This includes everybody, especially Blacks, Hispanics, and Native Americans and other indigenous groups in this country. So please, next slide. Again, these are selected ABC pipeline programs aimed at starting from middle school all the way to subspecialty training, including for medical students and undergraduate or graduate students. I also want to give a shout out to Cardio Nerds, which many of the program directors have become familiar with at this point. Cardio Nerds is a program led by fellows at this point. It's a medical cardiology podcast created to bring high-yield cardiovascular concepts in a fun and engaging format for listeners of all types. The goal is to democratize cardiovascular education. This is what we've been talking about here. How do we make this process a democracy so that it serves the unmet needs of all? Promoting diversity and inclusion in the beloved field of cardiology, which we're all in this for a reason. So we, the ABC, is looking forward to the programs that Cardio Nerds is putting forward, and looking forward to selected partnerships with the Cardio Nerds group. So thank you for joining us today. And again, I would like to thank Dr. Quinn Capers, Dr. Donna Polk, Dr. Frank Silvestri, Dr. Vanu Menon, Dr. Melvin Eccles, Dr. Julie Damp, Dr. Carol Watson, Dr. Stephen Marks, Dr. Trey Clark, Dr. Narissa Hayes, Dr. Lindsay Dennis, and Dr. Francisco Corrado Medrano for joining us today. And I also want to thank the ABC staff, Mr. Alan Merritt, Ms. Tiara Dillenberg, our CEO, Ms. Cassandra McCullough, and you heard Dr. Philly being mentioned. She's our CEO who mentors Dr. Eccles. So thank you again for joining this program. I hope that you found it to be useful, and please look forward to future ABC workforce programs. Thank you very much. And again, we dedicate this webinar to Dr. Eric Sean Williams, who's gone way too soon. Rest in peace.